Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today we welcome Mark Goldfarb. He is a cardiologist, and today's Kevin MD article is Why the U.S. Healthcare System is Failing Patients and What Every American Should Know. Mark, welcome to the show.
Thank you. Glad to be here. Thrilled to be here, actually.
All right. So before we talk about the article itself, what led you to write it and submit it to Kevin MD in the first place?
I became a patient as the flip side. Rather than being on the physician side, I became a patient. And as my wife said, I was a civilian patient. I didn't have the easy access. I had some difficulties, some things that were upsetting to me, not so much on my personal health, but the delivery of care I received. And I wrote it out for myself just as a mechanism to vent. I shared it with my wife. She said, "Oh, that's pretty accurate." I shared it with some friends. Then I shared it with some med school colleagues and friends, some local colleagues and friends, and the response was quite positive and said, "Yeah, I've experienced this too, and this is disturbing, and you need to let the word out or share it with other people, a wider audience."
All right. Tell us your story. What happened to you?
So I had retired. I practiced in Nashville, Tennessee for 33 years, interventional cardiology. I retired, moved out to Park City, Utah, which is absolutely gorgeous. And I started having some health issues, some challenges. And, once again, I had no primary care physician, no other physician specialists. In the old days when I was practicing, I'd run into a colleague slash friend in the physician lounge and say, "Hey, I got this." And they say,
Mhm.
"Yeah, come on up after lunch, or I'll see you tomorrow morning in the office," so on and so forth. This became challenging. I'd ask people here who to go to. I went to one or two people. One left. One was not terribly, in my view, up to standard. And then I had a more serious issue. I had a rotator cuff surgery. And afterwards, about a week or so later, I became literally sick and septic. And I went back to the emergency room where I had the procedure.
Mhm.
And they immediately took me back to the operating room and had to take out all the hardware. I had a P. acnes infection. Lo and behold, they put me on an antibiotic, and I went to see the infectious disease specialist a week later. Very nice person. She looked me in the eye, said, "The cultures came back. The antibiotic we have you on should be good. We'll see you in a month." I said, "Well, do you mind looking at my shoulder? I mean, just looking." "Oh, okay. Yeah, maybe we'll do that." And then as she's about to leave, she says, "Should be good." I said, "Well, I'm a cardiologist, and maybe I'm overreacting, but you know, maybe there's a slight chance of endocarditis. I mean, I was septic, and maybe, could you listen?" Oh, okay, maybe. So she has to find a stethoscope,
Mhm.
and she comes in, listens, and everything is fine. But I go, that was not good care. Thank goodness I got better, did rehab, and I'm back to normal. I subsequently had some back and spinal issues. I went to see, I was referred to a neurologist who looked at me and said, I don't know. Do you mind if and right in front of me, do you mind if I look this up on Google?"
Mhm.
And then my total faith in this individual was gone. I was referred then to an orthopedic surgeon after we had MRIs and LS spine films. And lo and behold, very nice person, said, "This is what we could do. This is what we should do. You're more active than average, so let's wait." I told my wife, I'm curious what's going to be in the patient portal about the after visit summary.
Mhm.
Lo and behold, there was an entire physical exam,
Mhm.
including strength, range of motion, sensory, in addition to listening to my lungs and heart, which he never, ever, ever touched me. And I wrote him back on the patient portal and sent a note to the head of the university saying, on one level, this is fraud because you're upcharging, but that's not really what I'm concerned about. I'm concerned about, if I come back to see you in 6 months, You have no baseline for my strength or range of motion or sensory. These are serious, serious issues. And then lastly, I saw the internist, my PSA went up, and I said, maybe it's time to see a urologist. Okay, referred me to a urologist. Saw the urologist, said, let's repeat it.
Mhm.
We did. It was up a little higher. He said, well, let's follow this. I said, well, I've been following it for 25 years. It's now up. There's no good reason that it's up. Why don't we do an exam? You really can't feel that much on the exam because you only feel this side of the prostate, not the other side. And I don't think that's going to work. I said, please, let's do an exam.
Mhm.
He did an exam. There was a little asymmetry. Thank goodness he said, okay, let's get an MRI. And that led to a further evaluation. But I found all three of these incidences very disturbing, disappointing. And then I think, if not being in the medical field, the average person, including my wife, would not have known to ask for certain things. You have to be your own advocate. And I'd say 98% of the people are not in the medical field and don't know to ask, nor do they think it's fair to ask.
Now, of course, you've been practicing cardiology for decades before this.
Mhm.
So, from your lens as a physician, what do you think are some of the root causes behind some of that substandard care you received?
I hate to say this, maybe I sound like a dinosaur. I don't know if it's in the training, but I think current day physicians, and they could argue with me, are more attuned to ordering first, and then treating and addressing test results. It looks good in black and white. I could treat that. The nuances seem to be missing.
Hmm.
And it may be in the training. It's been brought to my attention. I understand there's what appears to be a severe shortage of physicians. So maybe there's a time crunch. A lot of times you end up seeing the PAs and nurse practitioners, which are wonderful. They're truly wonderful assets. My daughter is a nurse practitioner, so I'm fully for that. But when you go to see a physician and you first see the medical assistant, PA, or NP, I'm not sure what the communication is or if they're just doing it to fill in the EMR, but there's a lack of communication. And then it kills me when you see the physician and they're staring at their computer and barely making any eye contact.
Hmm.
The rapport in the room is totally missing. It's a cold encounter. It's almost like a business encounter rather than dealing with a person who's ailing and went to you for help.
When you were practicing cardiology, did you feel outside forces that influenced some of the care that you gave out?
I did not. Maybe I think I was very, very lucky. I was in a good practice. We were owned by a hospital at a certain point, and maybe they had more decisions about how many staff people, et cetera. And maybe they did the hiring, and maybe I might not have hired one or two, but overall, I didn't feel pressure to produce or meet certain thresholds. I felt independent, and I think it was a good milieu.
Now, when you offered that feedback after reading that note, did you receive any response or rectification?
The physician apologized directly, called me actually, which I felt was appropriate, and said, oh, he was sorry. He was on call the night before. His MA was typing everything and he didn't check it. Well, I appreciate the apology, but it still falls short of, I don't know what you did in the next patient, to the next patient, the next week, the next month. It's your responsibility. Everything that your medical assistant, PA, nurse practitioner puts in the chart ultimately is your responsibility. So maybe it was a learning experience, or maybe it was just, okay, I'm going to get rid of this guy and I'm going to move forward.
So, what are some paths forward? You mentioned some things about the training, perhaps. perhaps there's external forces that may be pressuring these clinicians to provide lesser care than they would like. What are some paths forward from your perspective, not only as a retired physician, but also from your experience from the patient side as well?
I want to correct one thing. I like to use the term semi-retired because
Perfect.
I do volunteer at a clinic for people who don't have health insurance. And what's nice is I'm seeing the patient the same way, but I'm not worried about filling in the EMR and what level of service, so on and so forth. And it's a pleasure to do that where you're doing things because it's the right thing to do.
Mhm.
Now, you need to document well because the patient's going to be seen, in my situation, by the primary care physician, and I will see them in several months. So you need to have accurate documentation, but you're not worrying, is this a level 3, level 4, etc.
Sure.
What can we do going forward? It's tough. I think it starts with the training. I- Some of it is just basic human, just look the patient in the eye. And I think every physician should also have to go through the process of the patient journey at least once a year. Try to, I mean, I don't know how they would do this, but make it a mock patient. You call in to get an appointment. You're having, in my situation, you're having chest pain. And they say, okay, we can see you in 6 or 7 weeks. Well, that's not appropriate. And so then you need to call a friend to get you moved up. And then maybe there's an opening in a week or two, which is better, but the roadblocks to getting care are absolutely horrendous. And we need to address that. And that's whether it's numbers or there's a ranked system in terms of severity of symptoms. And then we also need more primary care physicians. We treat too many basic things in the emergency room, which drives up costs dramatically rather than seeing them in the private office.
Now, did your experience as a patient, did it surprise you? Did it surprise you
Shocked me.
the care that you received?
Absolutely shocked me. Both the difficulty getting in, the difficulty getting a follow-up appointment, the difficulty finding the after visit summary in the electronic medical record, the difficulty understanding the bill. I mean, that's almost hieroglyphics. I had no idea. You know, you were charged this, this is what's accept usual and customary, this is the, and then at the very end there, this is what you might owe. So that's impossible. The lack of one major thing is the lack of communication between the physicians. I mean, once again, call me a dinosaur. So I would, patient was referred to me by a friend who was a primary care provider. Rather than just send a note, I would usually say, oh, let me just call him or her and communicate directly. Right now, it's in the EMR, and someone puts a note there. And you could also go off on a tangent on EMRs, which is vast majority cut and paste, but you have to search for the essential meaning and interpretation, what the physician wants to convey. So that's a major issue that needs to be addressed. I know the EMR is not going to go away, but we need to utilize it in a more proactive, positive manner.
Now, when you were practicing cardiology before your semi-retirement, did you have to grapple with all these EMR implementations in your own office?
Absolutely. Yes. Yes. And, you know, they would change vendors every couple of years. They would update things. You'd have the men and women in the almost the construction worker vests in the hospital helping you in the hospital trying to figure it out. No,
Ho-
it's very challenging.
And then how did you manage looking that patient in the eye with the distraction of the computer in the exam room? How did you maintain that relationship that you had with the patient in the exam room?
I refuse to be in a room with a computer. I would never bring it in, ever. The patient physician interaction is the paramount point of what you're doing each and every day.
And in terms of your experience as a patient, is it unique to your area or is this happening all across the country? Are you hearing your colleagues whenever they seek medical care, are they going through the same experiences as you were?
Based on me distributing my letter or editorial to physicians, former friends and physicians all over the country, everyone says oh, I've experienced that. And it hurts as a physician, but I've had one or two friends with very serious health issues who have said, oh my goodness, you're telling exactly what I have experienced. I thought I was going to die, and no one, it was terrible.
Now, you alluded to this earlier in terms of physicians needing to communicate with one another. Physicians needed to look patients in the eye when they're talking to them, despite having electronic medical records and computers in a room. What other pieces of advice can you share with the clinicians listening to you today? And they may be going through burnout and all these external pressures, but despite all that, tell us the messages and a piece of advice that you want to give to clinicians to maintain that patient relationship despite everything else going on with our healthcare system.
Is have integrity and be honest. So when you fill out the EMR, don't hit a template which says normal.
Mm-hmm.
Don't, in some capacity, let the MA totally populate the history. Use your interpretation, use the patient words rather than the patient was on the portal the night before, hit yes, no, whatever.
Mm-hmm.
It has to be totally accurate and with integrity. And above that, perhaps most important, treat every patient like you would your mother with respect, honesty. You can put your hand on their shoulder. We'll get through this together. I understand what you're experiencing. This is what I think it is. If you want a second opinion, feel free. And let's work through this together. And I will be here for you.
How about advice to other patients? Because you also mentioned that if you weren't a physician yourself, you wouldn't have pushed and asked these follow up questions. A lot of patients simply would have just accepted their
Correct.
experience with the physician. So tell us what kind of advice you have for patients going through the healthcare system and experiencing the same roadblocks that you faced.
I think it's almost imperative that each patient bring a family member with them.
Mm.
Particularly, my parents are in their late or were in their late 90s. They both passed in the last year or two, but they can't navigate the patient portal. And when they're sitting in front of the physician, they're intimidated. They get their answers go way off track. You need to have a family member or a trusted friend with you, both to listen, to give you feedback after the visit, and to be a patient advocate. Because elderly people cannot manage the portal, they cannot set up appointments. The medicine reconciliation list is a total disaster and needs to be reviewed on each and every visit. You just need somebody with you as a second voice and second set of ears to make sure things are going the way you hope it goes.
You mentioned earlier that there's a severe shortage of primary care physicians. I'm a primary care physician myself, so of course I agree with you and I see that. Now, from a policy standpoint, what can be done? Because it seems like we've been talking about the lack of primary care physicians for decades now, and the needle hasn't really moved. So, if you were in charge of our healthcare system, what are some things that you would do to help with the primary care shortage?
It's a very good question. I'm not a policy person. Your comments are right. It's been going on forever. I think everyone should be referred to and read that Commonwealth Fund article, which ranks us out of 10 similar high-income countries in the world. We are 10th. We are last in terms of access to care.
Mhm.
So it's not a surprise. It's absolutely here. We need more primary care physicians, and maybe it needs to be a financial situation where we are incentivized for preventing disease rather than simply reacting to a crisis. So I know all physicians are incentivized for doing a procedure.
Mm-hmm.
I mean, in my group of cardiologists, when I was practicing, you put patient X on my stretcher and in the cath lab, and I have a reputation, and I think appropriately so, for being conservative. I'd say there are one or two, three people in my group, they'd come out with a stent because they're incentivized for doing something. And it's nice to make pretty pictures and get rid of a blockage, but because you can do it, the big question is, should you do it? So we definitely need more primary care providers, and we definitely need something with the system incentivizing physicians to stop disease before it becomes a major issue.
We're talking to Mark Goldfarb. He's a cardiologist, and today's KevinMD article is Why the U.S. Healthcare System is Failing Patients and What Every American Should Know. Mark, let's end with some take-home messages that you want to leave with the KevinMD audience.
I think I mentioned it before, but treat every patient like you would your mother and your immediate family or your children. You need to have integrity, look them in the eye. We can get through this. The EMR is not going away, but be honest with what you enter. Treat every patient with respect. Establish a rapport. Probably the best part of my practice is when I retired, the letters I got, because I feel I did a good job establishing a relationship. And I've been, retired from that practice for 5.5 years. I still get phone calls, I still get letters, and that is the most gratifying thing ever.
Mark, thank you so much for sharing your story, time, and insight. Thanks again for coming on the show.
Thank you, Kevin. I appreciate that.